Assalamu alaikum. My talk today is about brachytherapy flow in unusual cases. Indeed, still trabeculectomy, the golden standard surgery for glaucoma, which giving us the effective lowering of the IOP for the long term for most of the patients. And we always looking to do this surgery for our patients. But sometimes we have challenging cases, difficult cases, operated cases, which trabeculectomy can carry some complications, and these complications can affect the eye seriously. So we are trying to avoid trabeculectomy and go for tubes or shunts, which may be more safer to avoid these complications. In general, we are still taking trabeculectomy as the first choice for our unoperated eyes, and taking shunts and tubes as the first choice when the eye is operated, or when it's unusual case as vitrectomized eye or high myop eye or ophthalmos eye, as tubes or shunts can be more safer to avoid the post-op hypotony or other complications. Indeed, tubes and valves, there are some limitations for their use. For example, we all know that Ahmed valve doing well in the first period, but later on we will face encapsulation, hypertensive phase, and we have to add anti-glaucoma drops to control the pressure. In Pervelt, maybe the IOP lower for longer time, but the hypotony in the first period can happen with most of our cases. Indeed, brachytherapy flow now introduced it as MIPS, minimum invasive bleb surgery, which can give us a bleb for glaucoma control as trabeculectomy, with less complications which can happen with us with trabeculectomy. So can we take the benefit of brachytherapy flow as a trabeculectomy, or modify the trabeculectomy to these unusual cases of glaucoma to avoid the complications? Let us or start from this study, which after comparing micro shunt brachytherapy flow with trabeculectomy, giving us that no significant difference between both of them in controlling pressure, but with the brachytherapy flow the visual field progression was less, and the hypotonic maculopathy risk was less also. So we here started to use brachytherapy flow for these cases. I will highlight three main cases: high myopia, post-vitrectomy eyes, and ophthalmos eyes. In high myopia, usually the challenging coming from the sclera, which is thin, and the increase of hypotony, maculopathy, post-op, choroidal effusion, and the conjunctiva fragile usually, and it's difficult to manipulate with. We have to avoid in brachytherapy flow dissect the conjunctiva widely as we do in the regular cases. We try to avoid the superior nasal quadrant because the sclera will be thinner in this area. Try to go for the temporal upper quadrant, and we can minimize the time of mitomycin. In post-vitrectomatous eyes, the vitreous is removed from the eye, and the eye is more susceptible to be collapsed if the pressure dropped suddenly. And any residual vitreous made in the anterior chamber can plug the lumen of the brachytherapy flow. So in these cases, we have to first avoid the area of the which operated previously by vitrectomy. So if the temporal upper quadrant is already operated, we have to go to the superior nasal quadrant. But here we have to dissect widely the conjunctiva because the fibrosis is more aggressive in these cases, and we have to use mitomycin also in a longer time. In ophthalmos, that's sclera thin, and we have to take the tunnel lesser than usual. It's just 2 millimeter to avoid perforation. Mitomycin should be taken carefully upon the thickness of the conjunctiva and the tenon, and we have to avoid advanced cases like cases with cornea opaque, because we have to see the implant inside the eye. I'm not encouraging to use it in the pediatric group, but for some patients whom are now adults and operated previously, and now they need surgery, the eye ophthalmos, but the patient not young, not in the first few years of the age, we can do Preseriflow with cautions. I will suggest also stenting the Preseriflow for all these cases, because stenting can give us a control for the pressure, mainly in the first 2 weeks or 3 weeks. Then we can remove this suture from the lumen of the stent, and at the end, after 6 months, we can have the same pressure as the implant not stented before. Thank you very much.